Hello, everyone. Happy Sunday to you. Welcome to Spilling Tea. I am your host, Tiffany Daniels. Now, folks, we are going over once again back to the JRC and back to the FDA Executive Summary for April the 24th, 2014. Few things before we go ahead and get started. First of all, as always, the link to this executive study can be found in the description box, as well as the petition to shut down the Judge Rotenberg Center. If you have not already signed the petition, please click on the link, sign it. You can leave a comment if you like. Also, folks, some of the things that we discuss during these videos while we are covering the Judge Rotenberg Center are extremely disturbing. Oftentimes, we will be speaking of actual torture. So if you have young ones in the room, please, when you watch these videos, use your headphones. All right? Perfect. So, we stopped yesterday at 4.4.4. Now, before we get into this, if I happen to stumble on any scientific jargon or just over my words in general, I apologize in advance. All right, so let's go ahead and get into this. Summary of benefits and risks of treatment for SIB. Again, folks, that is the acronym for self-injurious behavior. Treatment of SIB and aggressive behavior essentially falls into two broad categories: pharmacological and behavior. Currently, there are no unpublished consensus guidelines or practice parameters for the treatment of SIB and aggressive behavior for individuals with limited intellectual ability or developmental disabilities. Review of published literature suggests that behavioral treatment should be the first-line treatment, notably when environmental factors contributing to occurrence of SIB and aggressive behavior can be identified. They can be anyways. It's called use your brain. Just because we don't communicate verbally doesn't mean we're not communicating in other ways, you idiots. Behavior is communication. God, how do you all have degrees? However, these does not appear to be any consensus in the literature regarding the type of behavioral intervention that should be employed first. Pharmacological interventions are typically used in conjunction with a behavioral treatment program or when patients do not respond to a behavioral therapy. With the exception of the studies which investigated opiate agonists and, here's going to be one of those words I butcher, clompramine, the majority of the pharmacological and behavioral treatment studies are largely confined to small sample sizes or single case reports. Few studies are controlled studies or comparative investigations. Despite numerous methodological limitations of these studies, overall both pharmacological and behavioral interventions appear to be relatively successful in reducing but not completely eliminating SIB and aggressive behavior in persons with intellectual and developmental limitations. This may largely be attributable to the fact that the majority of these studies are limited to either a single case report or a small case series in which a beneficial effective treatment was found. Reporting of adverse events with exception of pharmacological studies is sparse, and few behavioral studies report adverse events. The only exception is for the use of extinction in which there is potential risk of so-called extinction bursts, which is upsurge, particularly in the early stages of the intervention. Gee, you think? Of the actual undesired and unwanted behavior. If this upsurge in behavior poses a danger to the individual and or others, then an extinction paradigm is not a feasible option. Lerman et al. 1999. Recently, Matson and colleagues suggested guidelines for the treatment of SIB and aggressive behavior in individuals with autism spectrum disorders. However, these guidelines are not evidence-based, and represent the author's assessment of effectiveness of the available published literature. The suggested guidelines include a functional assessment should be employed to determine whether clear environmental causes are evident. Research shows that environmental variables may account for up to 80% of challenging behaviors in adults with intellectual disabilities. Madsen et al., 1999. Gee, ya think? I could have told you that. God. Behaviors communication. Get it through your heads. Where environment factors are not evident, medication should be considered. However, broad-based and comprehensive side effect evaluations need to be completed periodically during drug administration, and even more frequently during drug titrations and increases in dosage. Medication should be a temporary solution. As behavioral treatments may take some time to lead to behavioral change, medication may be needed in the short term, but then may be able to be faded out with continued use of behavioral strategies. Treatment of SIB and aggressive behavior in persons with intellectual or developmental limitations should be multidisciplinary. Individuals with intellectual impairment and developmental disabilities have varying levels of cognitive ability, which must be considered in determining possible treatment interventions. For example, persons with severe or profound intellectual disability lack the cognitive capacity to understand the relationship between their behaviors and the reinforcement contingency, be it positive or negative, that is applied. Well, that's a huge assumption on your part, isn't it? You have no idea what they understand and what they don't. You're just making a judgment, you stupid neurotypical. For some individuals, principles of classical conditioning in which a conditioned response is learned, i.e., not to engage in SIB and aggressive behavior, may need to be applied. For these cases, aversive techniques such as restraint, ammonia, facial screening, etc., may be effective more than the traditional reinforcement schedules used in cognitively intact persons. Yeah, if you want to engage in torture, sure, why not? God, I hate these people. Let's encourage people to face screen people just a step above waterboarding. Why not? Alright, so we are moving to a new part of the summary. Number 5, benefits and risks of ESDs for aversive conditioning. This section examines specific information regarding benefits and risks based on adverse event complaint reports to public agencies, prior reports, reviews, and public proceedings that have been provided to the FDA or discovered by the FDA. The statutes and regulations require FDA to consider all available data and information in making a banning determination. Data and information were considered from various sources. 2 systematic literature reviews are performed by the FDA to identify benefits and risks associated with the use of ESDs, which is electric skin shock devices, by the way, for aversive conditioning that fall within the scope of the proposed ban. The review of benefits focused on self-injurious behavior and aggressive behavior. FDA believes that the adverse events reported for ESDs for aversive conditioning may be generalized across indications, and therefore information regarding AEs from other indications is presented for the panel consideration. Most of the literature identified pertain to SIB for developmental disabilities. Other medical indications for use of ESDs for aversive conditioning as reported in the literature include the following: alcohol and other substance abuse dependence, assaultive destructive behavior associated with psychiatric disorders, developmental disabilities. Cerebral palsy? Really? You're going to shock people for having cerebral palsy. God, can you get more disgusting? Smoking cessation, schizophrenia, severe obsessive compulsive disorder, trichotillomania, trichotillomania, weight loss. You're going to shock people for weight loss? What the hell? Better not exercise, folks. They're gonna shock you. Oh boy. Okay, moving on. FDA Systematic Literature Review. The FDA conducted a systematic literature review to assess benefits and risks of ESDs for aversive conditioning. 5.1.1 Methods. Separate searches were conducted to examine published literature for the treatment, effect, and adverse events associated with ESDs for aversive conditioning. Electronic searches were undertaken of Embase, 1980 to present, Medline, 1966 to present, and PsycInfo. Search results were limited to English and human. For treatment effect, we searched databases using the medical subject headings term treatment outcome and following the device identifiers graduated electronic decalator, or GED, or self-injurious behavior inhibiting system, or SIBIS, or stimulatory sonic control, or whistle stop, or electrical stimulation, or electrical skin shock, or electric shock, or electric skin shock, or aversive conditioning, or aversive shock, or aversive stimulus, or aversive stimuli, or aversive treatment, aversive control, aversive conditioning treatment, or aversive electrical treatment, or electrical aversive treatment, or electrical aversive conditioning, or aversion therapy, or electrostatic shock, or contingent shock, or responsive contingent shock, or contingent electric stimulation, or contingent electrostimulus, or contingent electric stimuli, or therapeutic shock device, or behavioral decalator, or punishment, or operant conditioning, or noxious stimulation, or noxious stimulus, noxious stimuli, noxious conditioning, or behavioral reduction. A similar search strategy was employed for adverse events, but because of the large number of returned results, the strategy was modified. We searched the databases using the MESH term. Oh God, I'm gonna have to read through all of this, aren't I? Alright, here we go. Adverse effects, or side effects, or undesirable effects, or injurious effects, and the following device identifiers: graduated electronic decalator, or GED, or self-injurious behavior inhibiting system, or SIBIS, or stimulatory sonic control, or whistle stop, or electric shock, or contingent shock, or punishment, or operant conditioning, or electrical skin shock, or electric shock, or electric skin shock, or aversive conditioning, or aversive excluded articles that contain the following terms: ECT, or elective convulsive therapy, or eating disorder, or anorexia, or incontinence, or FES, or functional electrical stimulation, or acupuncture, or defibrillator, or cochlear, or nerve stimulator, or GES, or gastric electrical stimulation, or VNS, or vagus nerve stimulation, or biofeedback, or brain stimulation, or audiometry, or analgesia, or anesthesia. The articles were reviewed for relevance to the review. Title and abstract review was independently conducted for each search by 2 review team members. Potentially relevant articles were obtained. Any disagreements between the 2 primary reviewers were adjudicated by the entire review team. In addition to the systematic searches of the 3 databases, including review of the 2 search results for both benefits and risks, other potentially relevant articles were identified from other sources, including information submitted to the FDA prior to public proceedings on the subject, and bibliographies of articles identified in the original search strategy. Overall, the search yielded 57 articles, 12 reviews, 45 clinical reports regarding treatment outcome, and 39 articles, 12 reviews, 27 clinical reports regarding adverse events. These articles were reviewed in full for information on the benefits and risks, respectively, of ESDs for aversive conditioning for self-injurious behavior and aggressive behavior. 5.1.2 Benefits identified through FDA literature search. Oh God, I'm going to try not to rant. We're kind of running high on time here. Articles were reviewed for clinical information regarding the use of ESDs for aversive conditioning to treat self-injurious behavior or aggressive destructive behavior. No randomized controlled trials were identified. Wow, shocker. Remember that report I had you all watch where it said there was no confirming data? A total of 45 studies were identified, and including the following 41 case reports case series, 1 case control study conducted outside of the U.S., 1 within the subject's comparison trial conducted outside of the U.S., 1 retrospective review of 60 patient charts conducted in the U.S., and 1 questionnaire follow-up study of 22 subjects. 11 responded had received ESD for aversive conditioning conducted in the U.S. All these studies can only be found in one place, folks, because only one place uses this sort of conditioning on their students, which is the Judge Rotenberg Center. Remember when I said no outside sources really corroborated what they were doing? That's what I mean. Okay, moving on. There were 26 articles published before 1980, 12 articles published from 1980 to 2000, and 7 articles published since 2000. Only 3 groups of U.S. researchers have published in this area since 2000. The higher quality publication was a case control study by Duker and Says, 2000. They conducted a prospective case control study of 8 subjects with SIB compared with 8 matched controls. The primary outcome measure was amount of mechanical restraint required for each subject. Though no statistical analysis was conducted, the author reported an 82% decrease in mechanical restraint over an 8-year period for subjects receiving ESD. Limitations of the study are that the primary outcome measure did not directly examine self-injurious behavior and no statistical analysis was conducted. Ain't that convenient? The other comparative report was of a within subject's investigation at baseline and with the ESD applied. Again, that's elective skin shock device. Duker and van der Munkhoff, 2007, examined the heart rate of 5 individuals being treated for severe SIB with ESDs. They noted that when the individuals were wearing an active ESD, their heart rate was significantly lower than when they were not. They concluded that the individuals were less anxious when an active device was applied. Limitations of this study are that the heart rate has not been demonstrated to be a valid marker of anxiety. True. Moreover, the association of heart rate or anxiety with SIB has not been established. So they're trying to say because their heart rate was lower, that means that the device made them less anxious. However, the rate of one's heart is not necessarily a good measure when it comes to anxiety, as it does take many forms, as we are all aware. Some of us are really, really, really good and have extreme self-control and can seem perfectly fine when our anxiety is through the roof. So, just wanted to put that out there. Of course, it's going to have Israel. Israel et al. 2008 conducted a retrospective chart review of 60 patient charts at a special needs education facility who had received ESD for aversive conditioning as part of their treatment program. They reported use of 2 different devices, the GED-1 and the GED-4. They concluded that the ESD use as a supplement to positive programming was effective, defined as a 90% or greater reduction from baseline in 100% of the patients. Of course he's going to say that. Of course, he wants that money. Remember, folks, we're talking about people who get $285,000 in funding per student. So, of course, they're going to say it's 100% effective. They're sick bastards. Moving on. Murphy and Wilson, 1980, conducted a follow-up study of subjects who had received ESD for aversive conditioning. They sent questionnaires to 22 identified subjects and received 11 responses. Reviewing the responses, they found that relapse, defined as a marked increase of self-injurious behavior after treatment ended, occurred in 7 of 11 successfully treated patients within 2 years after treatment ended. 2 subjects showed continued suppression of SIB symptoms. That is to be expected. See, when you are in an abusive situation, you're going to do what you need to do in order to get not abused. When you factor in PTSD, once these folks begin to realize that they are no longer going to be abused or punished due to behaviors over which they have no control, they're going to pop out. Remember, I myself, and I do pride myself on my control. I've worked many years on it. But I still do exhibit what they would call these target behaviors, even if it's years and years apart. So, it would be pointless to try to treat me with this sort of treatment, because guess what? It's still going to be the same pattern. All you're going to do is just increase my PTSD. Like, I need help with that. Some subjects will either A, due to the PTSD, continue to refuse to exhibit those behaviors for fear of more punishment and abuse. By the way, it's really sick when you feel the need to condition people to be normal so that they can be acceptable, so you aren't embarrassed with us. Just saying. Moving on. 41 case studies with 105 subjects containing specific clinical report information were identified. We'll look at the table here in a moment. The case reports case series are generally supportive of the effectiveness of ESDs for SIB and aggressive destructive behavior. However, in many cases, use of ESDs for aversive conditioning occurs in conjunction with other treatments. Positive treatment programs, behavioral and functional treatment programs, medications. Therefore, it is not possible to assess the treatment effect due to the ESD alone. Isn't that interesting? Additionally, many reports only assess short-term effects or do not specify the length of follow-up assessment. 14 studies, 29, report assessment of 6 months or less, while 8 studies do not specify a length of follow-up assessment. 18 studies do not report results past 6 months, with 1 case report showing benefit out of to 5 years. Of those, 12 reported long-term benefits past 6 months, though some reported maintenance use, continued periodic application of ESD, or the use of other treatments during the assessment period. One article, Brule et al. 1982, noted mixed results of 7 subjects. 4 had near complete suppression of SIB within the first 2 weeks, and the effect was sustained by the occasional booster shocks for 1 to 2 year follow-up periods. 3 showed partial or transitory results. For 2 of those, reinstitution of contingent shocks treatment was not successful. In another article examining inpatient use of ESD in conjunction with a variety of behavioral and functional treatments over 3 years, Browning, 1971, for SIB, there was complete response in 1 and partial response in 1 subject. For aggressive behavior, there was complete response in 2 subjects and partial response in 3 subjects. Even after 35 months in the intensive behavior modification program, response approximations previously extinguished behavior were still elicited. The authors concluded that to maintain a child's behavior at the level occurring at the date of discharge would require very close one-to-one supervision in structured activities in order to retain the child's attention, newly acquired behaviors, and to prevent the retrieval of those habits which had been extinguished. They're not habits, they're part of our disorder. Get over yourselves. One study noted that initial effectiveness and overall duration of effect may be related to stimulant intensity. Williams, Kirkpatrick, Sanchez, Iwata, 1993. While another article that demonstrated effects up to 8 years, Duker and Says, 2000, concluded loss of effect of previous reports was due to the use of lower level stimulation. Of course they would. If we just turn it up, make it hurt a little more. Maybe if we can burn the skin, it will have a better result. The hell is wrong with these people? These findings suggest that effectiveness and duration of effect may be dose dependent. Jesus Christ. Higher intensity stimulation is associated with greater effectiveness and longer duration of the effect. Let's burn the hell out of them, then it will last forever. Yeah, the PTSD certainly would. Okay, so here's the table, guys. This is some of the studies that we were just covering. Yeah, they ever tried to use that on my nephew. You want to talk about... They want to see an autistic snap? Try strapping one of those on my nephew. I'll give you an autistic snap. Real quick. And I'm just scrolling through them because we pretty much already read this. 4 years old. Oh my God. 4 years old. 7, 5. 4 years old. 11. 9. God, these people are sick. Oh, so they started to not want to tell us the ages. Why is that not surprising? So you can see basically all the tables here, various ages where they're using the shocks. Pretty much all the data we're taking a look at, if it comes before 1980, it's all being provided by the Judge Rotenberg Center. Isn't that interesting? In addition to the publications in Table 3 that included specific clinical information on individual subjects, the following 12 review articles, without new clinical information, examining the effectiveness of ESDs for aversive conditioning for various etiologies were evaluated. Asman and Holtz, 1966, Problematic Behaviors. Bachman, 1972, SIB. Corbett, 1975, SIB. Logan and Turnage, 1975, Behavior Problems General. Lechstein and Schriebman, 1976, Autism. Frank and Simmons, 1976, Schizophrenia and Intellectual Disability. Carr and Lovis, 1981, Severe Behavioral Problems. Lovis, as we've gone over before, by the way, has since repudiated that study. Singh, 1981. Fox, Plaska, and Brittle, 1986. Aberrant Behaviors, including SIB. Lernan and Borden, 2002. Myers and Evans, 1989. Behavioral Problems General. Except Levis and Holden, 2006. Aberrant Behaviors. Again, he has since repudiated all this, thank God. Moving on. These reviews generally supported the conclusion that ESDs for aversive conditioning for SIB and aggressive destructive behavior demonstrate short-term effectiveness. Like Stein and Schriebman, 1976, conducted a literature review, specifically examining reports of using ESDs in autistic children. They noted that in all these studies, electric shock proved to be a highly effective therapeutic agent with autistic children, and estimate that the positive effects compared to the negative effects occurred at a ratio of 5 to 1. They also reported that the lack of long-term durability, as well as setting the specificity of the results, may be an obstacle to an overall satisfactory effect. Gee, you think? Really? I wouldn't have guessed. Yeah, you're going to get that temporary person who behaves because they don't want to get skin shocked again. But you take them off the skin shocks, and guess what's going to happen? Yeah. In terms of positive behavior effects, they included response generalization and increase of social behavior. How the hell do you figure that? And positive emotional behavior. Crack you smoking. You're on crack. But they're smiling more. Sure, they're gonna do what you tell them to do so that you don't do that again. Do you all not know how abuse works? Negative side effects are discussed in Section 5.1.3. A number of reviews specifically examined long-term effectiveness. Logan and Turnage, 1975, Lichtenstein and Schriebman, 1976, Frank and Simmons, 1976. One review, Learned Vorden, 2002, concluded that ESD may have long-term effectiveness, while Logan and Turnage noted that the effect appeared to be short-term only. Symptoms are only momentarily suppressed. Frank and Simmons, 1976, in a comparison of different treatments for controlling behavior in individuals with intellectual disability or schizophrenia, noted that in terms of immediate effect, punishment was the quickest means of suppressing the behavior. Okay, whatever, you sick bastard. For longer-term effects, timeout programs fared the best, followed by differential reinforcement techniques. In marked contrast to short-term effects, punishment and extinction programs seem to have the least durable success. Gee, I wonder why. In summary, the literature review generally supports short-term benefit of ESD for aversive conditioning for SIB or aggressive behavior. The long-term benefits are less well established. The role of stimulus intensity and the use of other concurrent treatments are not well understood, but may significantly impact study results. Limitations of this review include the fact that the majority of articles were case report studies published in the 1960s and 70s, prior to modern publication standards, and consequently do not adhere to established study conduct and reporting standards. No comparison trials directly examining ESDs for SIB and or aggressive behavior were identified, and a prospective case control study examining ESDs for SIB did not use a direct measure of SIB as the primary outcome. Primary outcome was a decrease in mechanical restraint. It did not conduct a statistical analysis. Okay, so basically what they're going over here and what they're stating is this is what the studies show in regards to what looks like are the positives of using electric skin shock devices. But what they note is all of these studies come before basically modern medicine as we know it. It comes pretty much all 1960s, 1970s, except for what they were spoon-fed them by the Judge Rotenberg Center, which that was a very different time for the medical world. Medical standards and what is considered humane treatment in the larger medical circles now is a lot different from what it was back then. So what they might have considered back then as okay for treatment would abhor, shock, and horrify those of us today. So, a little bit more longer than I was intending to go today, but that pretty much covers it, folks. We'll be getting and going through the risks of ESDs tomorrow. I'm actually proud of myself. I didn't rant nearly as much as I thought I was going to rant today. So we are going to go ahead and close out here today, folks. I do appreciate your time with us. Before you head out, however, please, we don't get that many views on this channel, and the few that we do tend to get removed from time to time. So if you could do a favor for me, please don't forget to hit that like button. Hit subscribe. Don't forget to hit the comments. Blah blah. Brain dead. I do appreciate, again, your time this afternoon. And as always, folks, we here at Spilling Tea hope you have a good one. One last thing. I will be doing a video tomorrow. It's just going to be coming out a little bit later in the day. I am going to be starting my first day of training tomorrow with Wayfair, so just be patient with me. Again, guys, have a good one. I'll see you later.